So good evening and a warm welcome to all the dignitaries present here. I'm Shreyushi from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Planet serves as the digital partner for this event, hosted by the Indian Society of Pediatric Neurology, and the focus of
Neurosurgery.
today's session is Pediatric Neurooncology Management. So let's begin today's session, for which I would like to invite Dr. Shuhas sir to take over. So please proceed with the talk. Over to you.
Thank you, Tracy. Good evening, everybody. So this is another session of the virtual classroom of Pediatric University for residents and trainees. So wherein we bring about our own teachers from national and international faculties to give you the basics of basic and advanced issues of pediatric neurosurgery. As always, this is held on the last Sunday of the month, and this one has been just a gentle modification. And today's topic, as a part of our neuro-oncology session, is optochiasmatic glioma. As you all know, optochiasmatic glioma in children is a challenging one, where at one end, of course, it's a benign tumor. On the other end, it has several quality issues, beginning from the issues secondary to management and the long-term issues. So my colleagues, Dr. Arivazhagan, Dr. Maya Prasad, and Dr. Uday will deal with various aspects of this particular disease. Dr. Ari is my colleague from NIMHANS. He's a professor there, and he has his primary interest in neuro-oncology. So hence he will take up the surgical aspects and the allied aspects of optochiasmatic glioma. Dr. Ari, you can take up.
Yeah.
Thank you.
I'll share the screen.
Yeah. So for all the residents, you can interject any time if you have specific questions for any of our teachers, and stop them anywhere. So we'll have 15 minutes of each talk, and towards the end, we'll have another 15 minutes of an open session. And these talks will be available in the YouTube of the Industrian channel, so you can always go back and look at the sessions again and again. Thank you. Please put your questions in the chat box so that you can clarify whatever you wish to clarify during the session.
Okay. Is my slide visible?
Yes, clear. No problem.
I'm audible, right?
Start off. Yes.
Yeah. So good evening. So I thank the Industrian for giving this opportunity. It's always nice feeling to talk to residents and young neurosurgeons. And this is a topic which has more controversies and dilemmas than actual clarity, and it gives us a lot of place to think and individualize the treatment whenever we see a child with this problem. So let me give a short introduction about this condition, and I'm not going to talk much about the clinical features and imaging because it will be difficult to cover them. So I'm going to talk about general introduction and then followed directly by the various management principles, guidelines, and options available so that we understand them better. Okay. So optic pathway glioma or optochiasmatic glioma, whichever way they're called, they are a specific subset of tumors. If you take all the tumors in children, it's about 5% of all of them. Sorry, actually 1 to 5% of all tumors. And it occurs almost always in children. So it's a disease most often specific to pediatric age group. You rarely see them in adults. If you see in adult, it's most likely it has been an indolent lesion, which has become symptomatic in the recent time. Like I said, 90% of time they are diagnosed before 20 years of age, and 75% of them before 10 years of age. These tumors have got some special characteristics which we should know because this impact the management that we do. They are most often indolent, and if then they grow, they are slow growing. However, the caveat is the growth potential is not defined. It can be variable. In some, it can remain like this for years. In some, it can start growing fast. And rarely, in some cases, it is also seen that these tumors can spontaneously regress. So how are they divided? The management is not uniform. It depends on which part of the optic pathway it is involved. By rule that these tumors can involve any part of the optic pathway, starting from optic nerve all the way up to the optic radiation. However, they are most common in the region up to the optochiasmatic hypothalamic region. Rarely they can involve the optic tract also. So they are divided for better understanding and management. They are divided into anterior optic pathway lesions and posterior pathway lesions. The anterior pathway lesions involve orbital, intracanalicular, or prechiasmal intracranial lesions. They form about 1/3 of all the OPG gliomas, and you find them most often in prepubertal children. Whereas the posterior pathway lesions are chiasmal involvement, or they arise from hypothalamus or from the anterior third ventricle. So this is a breakup of various involvement areas across 100 cases of optic glioma presented. You can see that 1/3 of them is in optic chiasmus hypothalamus. You can find them in different parts. They can be involved in different permutation combinations of this area. It can be present as a diffuse glioma in some cases. So in short, that most it can involve any part, but most often the chiasmal or hypothalamic lesion is known. So why it is important? Because the management will differ, and there are some specific things which need to remember in management. So Dodge gave a classification of these gliomas into Dodge A, B, and C. Meaning A is prechiasmal, B is chiasmal, and C is hypothalamic. And later this paper in 2008 further modified them into functional classifications of optic pathway gliomas. Again, one is divided into 1B, A, B, and C. 2 is again divided, and 3 is divided, and 4 is posterior optic tract gliomas. So that, and having understood that, I would talk about management. Before I start talking about management, the few points I want to say is these tumors have to be diagnosed, and a very good thin section dedicated MRI of the brain and orbit is essential for making diagnosis, because this is one condition where often therapy would be started without an histological diagnosis. Therefore, a very good MRI and a radiological diagnosis is important before we diagnose this tumor. And clinical features will obviously depend on the location. So I'm not going much into detail of clinical location. So an important point that we need to remember in this patient, in this particular tumor, is a significant percentage of them are associated with neurofibromatosis or other genetic disorder. Therefore, why it is important? Because number one, to suspect these tumors early, and number two, the natural history of this tumor differs between NF and non-NF lesions, and therefore identifying the syndromic patients are important than compared to sporadic tumors. So up to 1/5 of patients with NF1 will have an optic nerve glioma sometime during the life. It can develop. And therefore, like I said, the incidence of NF1 on the reverse in patients with all optic pathogliomas have ranged from anywhere from 10 to 70%. So both ways the numbers are significant. So whenever you find an NF1 patient, this has to be kept in mind. However, if you notice that half of the patients with NF1 with the tumor may not have a visual loss. So that it can be present as asymptomatic. So that brings to a point as to how do we treat these tumors? These are slow growing, sometimes indolent, can be present in syndromic cases, and may not have symptoms. So all these options are open. Sometimes there's an option to watch and wait and do regular scanning. You can consider for chemo or radiotherapy, and there are indications, specific indications for doing a surgical intervention. So how to decide this? These are the factors which will help us to decide whether the patient has an NF, what is the age of the patient, what is the location of the tumor, what is the visual status at the time of diagnosis, does the tumor cause mass effect or hydrocephalus. So all these factors have to be taken into consideration before we make a decision for the optimal management. So optimal management, like I said, is controversial. It has to be individualized and needs a multidisciplinary approach. And that's why this topic we are discussing with three different specialties like surgery and medical oncology and radiation oncology. So like I said, 1/5 of the patients with NF can develop optic nerve glioma. So does that mean that all patients with NF require routine imaging screening? If you look at the data, epidemiological as well as clinical data, there is no recommendation as of now to do routine imaging screening for every patient with NF1 for picking up the tumor. But what is important is to do a complete ophthalmic clinical examination for these patients with NF1, and then That is a gold standard, and follow-up of optic pathway. Visual acuity is most reliable to know whether the tumor is growing or causing a problem. So it can be done up to 7 or 8 years, those who are higher risk. And after that, the incidence comes down, and therefore it can be done every 2 yearly. So it is not mandatory to scan every patient with NF1. However, visual acuity and eye testing is more important. And in the setting of NF1, these tumors are found to be more indolent with minimal or no visual loss. However, there are recent papers which have come up which show that it is not the true always. And even in NF setting, there can be a variable tumor progression. Therefore, it needs some amount of caution in this setting. Like I said, clinical examination is mandatory, opthal test is mandatory. So again, when to intervene, there are no universally accepted guidelines. The treatment needs to be individualized. And therefore, like in case of visual acuity, a change in acuity would indicate progression, and would indicate management intervention. So we'll come to different uh, locations of tumor, that is Dodge A and B and C. So anterior pathway glioma primarily involving optic nerve, which are pre-chiasmal, which is classified as Dodge A type of tumors. So I'm going to talk about the surgery and role of surgery in these tumors. So if we discussed the epidemiology of the tumor, so its association with genetic hereditary syndromes, and what factors will influence the decision making. And the most important thing is to diagnose them clearly using MRI before we embark on the management. Now, based on the level of the location of the tumor, what is the management? And I would talk about only the role of surgery in this. So when you find a patient with an anterior pathway glioma involving an optic nerve pre-chiasmal, what is the role of surgery? The role of surgery is very limited in this patient. In case of a very typical imaging diagnosis, there is no role for biopsy. You don't have to do a diagnostic biopsy to confirm it's a tumor. And surgery would be indicated only if there is a painful proptosis caused by the lesion, or when there's a complete visual loss. Otherwise, a lesion involving an optic nerve alone, diagnosed by MRI uh, as optic nerve glioma, does not require surgery, and it can be managed with adjuvant therapy. So this is a 12-year-old girl with visual loss in left eye 6 months and had a mild proptosis. She had 6x6 vision uh, on the right, and then left side had counting fingers. And this is MRI shows a typical lesion, typical imaging feature of an anterior optic pathway glioma. Compared to the right side, the left side optic nerve is dilated, and it's expanded, and you can see that it is extending up to the region of the chiasm. The chiasm appears not involved. And she underwent radiotherapy. Um and after radiotherapy, you can see her visual acuity has actually improved, and vision also has improved 6/9 in the left ear, and she's on follow-up. Another patient, 9-year-old boy, decreased vision in right eye, no neurocutaneous markers, hand movement close to face on the right side. Here you can see this second case where the tumor is involving optic nerve as well as extending up to the optic chiasm. The left side optic nerve is preserved. You can see the chiasm is expanded unilaterally on the right and not on the left side. This patient also underwent adjuvant therapy, and no surgery was required because the clinically, imaging wise, it's a typical diagnosis. Come to Dodge B, where there is chiasmatic lesion. Again, biopsy would not be in years. I mean, of deco. This was what was told, but there is a paper in 2011 where they said typical imaging, there is no need for biopsy. And if there's NF1, no need for biopsy. But now, with the recent papers coming up, we are talking about molecular diagnosis of this tumor, and therefore our oncologists often ask us to do a biopsy to confirm diagnosis and do further molecular typing. I think Dr. Maya will cover that. So in these tumors, that is Dodge B, we do surgery now mainly to do a biopsy to confirm whether it is pilocytic astro or a pilomyxoid, and then for further molecular characterization. So a few examples of that. This is a 5-year-old girl with visual loss in left eye. You can see there's a large tumor here. The optic nerve seems to be normal, whereas there's an expansion of the chiasm with the large tumor extending into suprasellar and third ventricular region, enhancing very well. So this patient underwent biopsy, partial decompression, and the biopsy proved pilocytic astro, and then she underwent adjuvant therapy. You can see that only chiasm, because I'll show you this one of the videos where you will see in these patients, especially for neurosurgeons, you should understand this whole optic nerve and chiasm will be expanded. So it's difficult to identify which are the functioning fibers, which are not. So it's always safer to remove the extra axial, that is the exophytic tumor. So this is another patient, 9-year-old boy with, you can see this is a preoperative image where you can see the tumor is involving the chiasm. And we again did just to see how the tumor looks during surgery. You can see that after retracting the frontal lobe, this is olfactory nerve. You can see the whole optic nerve and the chiasm is expanded. I wanted to, yeah. So this is how the whole optic nerve and chiasm looks. The whole thing is expanded. So, and then you can see the normal surface of the optic nerve and chiasm. So, trying to remove more of this area can cause visual deterioration, which can be best avoided, and therefore, biopsy of the safe area or an exophytic tumor is, and partial decompression based on the exophytic tumor is sufficient. This again is a pielomyxoid astrocytoma. And this patient underwent adjuvant therapy, and then on follow-up, his vision has improved and is stable now for more than 3 years. The last region, which is the post-chiasmal region, which is which is the third ventricle tumor. These are primarily third ventricle region. Here, I think the role of surgery is more important and more applicable, because these tumors cause a lot of mass effect. They can cause cyst formation and can cause hydrocephalus. Therefore, surgery is required. Here, the exophytic tumor can be decompressed adequately, and they are also by relieving the hydrocephalus. Some people may need shunt. What is important is, while decompressing this part of this tumor, that is a chiasmatic hypothalamic tumors, one should make sure that you don't injure optic pathways which are in the floor of the lesion. This is a 2-year-old child. You can see that's a large lesion which is occupying the one side of the hypothalamus as well as in the cisternal region in the medial temporal, and there's a large cyst. So this patient required a shunt, and then the tumor, you can see this, I think we went through transtemporal transfillian approach. You can see a large tumor here which can be decompressed. And what is important is, as when we decompress the tumor, we should decompress keeping in mind, and the optic nerve, chiasm, and the tract fibers have to be preserved. Whereas all the exophytic tumors can be decompressed, and then the nerve medially, you can see this is a part of the nerve which can be preserved. Sorry. So this is a post-op scan where you can see residual tumor medially. The lateral parts have been taken, cysts have been decompressed. This is a pilocytic. There's another tumor. Whenever there's a tumor which is large and occupying third ventricle, I prefer to come from the top through transcallosal approach, because that gives adequate space to decompress this part of the tumor, whereas the lower part of the tumor, which arises from the optic chiasm and hypothalamus region, can be left behind so that the morbidity will be reduced. So the post-op scan, you can see that all the superior part of the tumor is decompressed, whereas the lower part of the tumor involving the floor of third ventricle and the chiasm is intentionally left so that the morbidity will be reduced and can be taken care by adjuvant therapy. So I think this particular, there are rare cases where the tumor comes from the optic tract. I will skip this for want of time. You may find a tumor like this, which is unilateral arising from optic tract with a large cyst. They also can be, because of the mass effect, they need surgical decompression of the tumor. I will skip this video. And then you can see that all the cyst has been decompressed. A small part of the lesion actually arising from the optic tract, which is enhancing in contrast, is left behind so that the vision is kept preserved. And this is a patient on follow-up post-adjuvant therapy. So points to note: the overall survival and PFS will differ based on the location of the lesion. You can see that those are intraorbital tumors do well compared to other region. The NF1 positive, NF1 associated tumors have a better overall survival compared to sporadic lesions. And this, I think Dr. Maya will cover, so I will not get into this. Lot of relevance and importance is there in these patients for adjuvant therapy, and there's a lot of discussion. that as to which therapy should precede what. This just I'm going showing you like no one size does not fit all in this case. It's not like you can say every, like you can say in case of glioblastoma, we say we do surgery, then followed by radiotherapy and chemotherapy. Does not fit here. In some patients, we may have to do surgery followed by adjuvant therapy. In some patients, adjuvant therapy is started with just with or without a biopsy. And when there is a recurrence or relapse of the lesion, failure of chemotherapy or radiotherapy, then surgery may be required, or radiotherapy may be preceded by chemotherapy in some conditions. So all the options have to be kept open, and the treatment has to be individual. This paper from Eric Buffet's group shows that you can see the color codes of chemo, radio, and surgery across different patients. It doesn't look the same. In some, they have started with chemotherapy in the beginning. In some, they have just waited and watched it. In some, only surgery was sufficient in few cases here. So the crux of the to be understood of the issue to be understood is each patient has to be individualized in making a management plan. So what was a discussion about a decade ago, and I think probably still hold good. Whenever there's a tumor, primary complete resection of a hypothalamic or optic pathway glioma is not recommended. However, we need to know surgery is important and necessary when there is a large tumor causing mass effect, when there is large cyst and decompression of the exophytic and hypothalamic tumors, where early surgical debulking is should be considered with acceptable morbidity. And these are the two papers which have come recently this year. In case if surgery is considered, you can see in this is a systematic review of all the pediatric optic pathway glioma papers published. Whenever surgery is considered in an intraorbital tumor, you can see that gross total and subtotal resection was almost 80%, because like I said, surgery is considered in this tumor only when there is complete visual loss and proptosis, in which case you have to remove the tumor. If you go in case of intraorbital tumor, you need to remove them completely. Whereas if you look at the other conditions, the incidence of gross total resection is less than 10%. You will not consider at all a gross total resection. Most of the time it is a subtotal resection. And visual improvement happens it remains stable in most of the cases and can deteriorate in up to 1/4 of them in case if you are aggressive. So to summarize, in Dodge A cases, enough associated usually observation is sufficient, and then decision for treatment intervention should be considered when there is a progression. In case of non-enough lesions, you can consider intervention or observation based on the size of the lesion and the visual acuity. And role of surgery in this patient is progressive disease or a complete visual loss, like I said, PL negative and proptosis. In case of Dodge B and C, again, in case of enough, you can wait and watch in early disease and consider chemotherapy. In case of non-enough, exophytic component needs to be considered for decompression so that the chemotherapy and adjuvant therapy can work better, and hydrocephalus should be relieved. And when there's a large cyst, that also have to be operated to relieve mass effect. Another important role of surgery in these patients is when the patients undergo chemotherapy or radiotherapy, and if there is a relapse or a regrowth of the lesion, then surgery should be considered early so that the mass effect can be relieved, and the early is better. Thank you. I will stop here and I will take questions later. And I think I'll request Dr. Maya to, we will next listen to Dr. Maya Prasad, who is the Professor of Pediatric Oncology from Tata Memorial Hospital, Tata Memorial Center, Mumbai. Her special interest is in optic pathway glioma, and she will talk to us regarding the chemotherapy aspects of this condition. Over to Dr. Maya.
Good evening, everyone, and thank you, Dr. Arivazhagan. I hope my screen is visible and that I'm audible.
Yes, please go ahead.
Yes. So thank you. That was an excellent talk, and I think a lot of the topic has already been covered. But I think I will stick to a lot about what adjuvant therapies, especially chemotherapy, is generally being used in children with optic pathway gliomas. I'm sure all of you who are on this talk know about how pediatric low-grade gliomas have an excellent survival, and it's the same for optic pathway gliomas as well, because the overall survival in these tumors is quite good. And compared to adult gliomas, pediatric gliomas are histologically as well as they're quite different in their molecular aspects. We'll come to that a little bit later. So first of all, let me just briefly tell you about a child. We had, she actually presented to us 2 years ago, at which time she was 3 years old, and she was symptomatic with headache and vomiting. Although there were no signs of raised ICP, we found that it was difficult to actually do her ophthalmology evaluation because she was only 3 years old. There was some fixation and she was following commands. However, we noticed that she had nystagmus. And unfortunately, on fundoscopy and BEP, we found that there was bilateral optic atrophy present. And here, I mean, I think we don't need a radiologist to say that this is a very large suprasellar mass involving the optic pathway, which is why she actually had this visual problem. So what are the clinical presentations? Just to be very brief, depending on the size of the tumor, the exact location along the optic pathway, the rate of the tumor growth, and the age of the child, there may be different presentations. And of course, we know that in these large tumors, there could be raised ICT. A large proportion of children have some form of visual complaints, of course, because they are along the visual pathway. They could be either just a decrease in the visual acuity, or they may be actually quite mild visual field defects. But sometimes children present with a great degree of visual loss, and sometimes some children are blind. That generally occurs in very small children who are unable to complain as they are losing vision. And it's only when the parents notice that the child is blind or has very low vision that they actually come to us. If there is a very gradually increasing hydrocephalus, they may present with macrocephaly. Endocrinopathies may be seen in children. Around half of children are supposed to present with endocrinopathies if the tumor is in the hypothalamic region. It could be growth hormone deficiency, or in slightly older children, they could present with precocious puberty. So if anyone wants to tell me what this spot diagnosis is, you could go ahead. But if not, I'll tell you myself.
Diencephalic
Yes,
syndrome. I don't know
yes.
whether I am allowed to answer.
Maybe not. But yes, this is indeed diencephalic syndrome. And unfortunately, we get a lot of children coming in this state because, they are not recognized early, especially because it presents in infants and toddlers, and their presentation may often go unrecognized, and generally failure to thrive is the presentation that occurs, and only then they find that there is actually a visual impairment as well, and then evaluation shows that there is a tumor. So one thing I would like to emphasize on is that all children need visual evaluation at diagnosis, as well as they need periodic monitoring. So what could be the visual evaluation? It really depends on the age of the patient and the ability of a patient to actually respond and give accurate assessment. So of course, visual acuity, there are various ways in which to do it in various age groups. Visual field is now, computerized visual field testing is available in several places, and which is quite short as compared to the conventional visual field testing. BEP, visual potentials, are useful in younger children, and there is something called flash BEP as well. Color vision also often deteriorates. It's not easy to find out, especially in younger children, but there are now lots of methods in which even smaller children can be assessed. And visual deterioration, as Dr. Ari already mentioned, is often an indication to treat. So again, as he mentioned, I just want to emphasize that always look for stigmata of neurofibromatosis. Sometimes children are very young, and the stigmata of neurofibromatosis, they develop with as age increases. So in an infant, you might not actually get any stigmata. You may not get Kappa-Allee macules or any such stigmata. And they may actually only develop once the child is on treatment or has completed treatment. You actually realize that this child actually has NF. So look at the child, look at the parents, and ask for a family history. And always try to get a history of any endocrine disturbance. Also evaluate for it. So I think we already heard about NF-associated optic pathway gliomas. I'll just skip this. But apart from NF, there are also other very important molecular features which may be seen in optic pathway glioma. So the RAS-RAF MAP kinase pathway here, which is also here, is almost universally activated in any pediatric low-grade glioma. So either via NF, which also goes via this, or non-NF also goes via this pathway. So it is BRAF mutation, this is BRAF mutation, BRAF fusion, and NF1 mutations. All three of this together account for 2/3 of pediatric low-grade glioma. The proportion varies depending on where the location of the tumor is. I'll go to this. So here, this is just an example of the posterior fossa low-grade gliomas, where BRAF fusion is actually found in more than 75% of cases. But in our area of interest, our location, which is in the suprasellar region, maybe around 30% of them have BRAF fusion, around 10% of them have BRAF V600E, and around 15 to 20% of them actually have NF. And the commonest histology we find is pilocytic astrocytoma. So what is the importance of BRAF fusion and BRAF mutation? There have been lots of studies which found that BRAF fused tumors do better than BRAF non-fused tumors, and BRAF mutation positive tumors do worse than those which are negative for BRAF, which do not have mutation. So mutation is bad and fusion is good. And this has been found to be very, very predictive of outcomes. So how do you manage? As Dr. Ari mentioned, this is very, very complex. It has to be individualized for every child. And this is the case for every brain tumor, but more so here, because especially in the optic pathway, it's a very fine balance between treatment as well as causing late effects. And sometimes there are indications to not treat as well. So you have to be aware of what exactly will happen if you treat and what will happen if you don't treat, and the particular balance between each modality. So we just heard about surgical resection. I've written it as a limited role, but we just also heard that there are actually increasing indications for very sophisticated surgical techniques as well. Radiation therapy, which we will hear about after this talk, used to be the most common modality a few decades ago, but now there is increasing knowledge of the late toxicities that may occur as a result of radiation therapy. So the age at which radiation is being given is pushed further and further away. And this is especially so because of the location of the tumors. A lot of them are near the hypothalamic region. So it would not be very wise to radiate the hypothalamus, which can cause permanent endocrine problems to that child. But of course, if it's essential, we'll have to do it. We'll hear about it later. So radiation therapy may be either deferred or it may be avoided in certain cases. And I would like to focus on chemotherapy as well as targeted therapy, which now has an increasing role. Chemotherapy has been around for probably the past 4 decades, and now it is often the first-line adjuvant therapy in most pediatric low-grade gliomas. And especially, it may be the first-line treatment, not just the adjuvant, but maybe just the first treatment if it is unresectable tumors such as the optic pathway glioma tumors. So what are the chemotherapies which are used? The most commonly used protocol is a combination of vincristine and carboplatin, which is given for about a year. Initially, it's given weekly, and after 3 months, once we assess and see that there is some response, we continue 3 weekly chemotherapy or 4 weekly, depending on what protocol we're using, for a year or maybe even more. So that's the commonest used protocol. There could be another protocol which uses only weekly single agent vinblastine. So it is only vinblastine monotherapy. So what happens when you give these chemotherapy agents? We know that low-grade gliomas and optic pathway gliomas are very slow-growing tumors. So unlike other tumors, other pediatric cancers which respond very, very quickly, and in fact, even medulloblastoma or other aggressive tumors may respond really very rapidly to chemotherapy, and you actually find a very good response to chemotherapy. Here, in low-grade glioma, because of the biology of the disease, the response may not be that dramatic. It may only be stable disease. And sometimes the reduction may be only mild. And it also depends on how much of the tumor is cystic and how much is solid. So, they may not be very dramatic responses. And often the disease is only stable. It does not progress. So, in a lot of cases, especially like this child I showed you now, with these large tumors, they don't really shrink a lot. They may be stable or they may shrink a little. But here in our case, in this 3-year-old child, we definitely do not want to irradiate the tumor right now at 3 years. So we will try to give chemotherapy, stabilize it, keep her under follow-up. And if it regrows, again, we could give a second line of chemotherapy. With these are generally the first and second lines of chemotherapy, which are used interchangeably. So we could use these chemotherapies, stabilize the disease, and if it progresses further, and if the child is of an age which is appropriate for radiation, we could give radiotherapy. So that is generally the philosophy behind chemotherapy in pediatric low-grade gliomas. So the treatment of NF-associated optic pathway gliomas, as Dr. Ari mentioned, there are some patients who are not treated. But here I would just like to mention that when they are symptomatic and need treatment, the chemotherapy of choice is vinblastine monotherapy, because there has been a randomized trial between vinblastine monotherapy and vincristine and carboplatin. This found that children with NF1 respond very beautifully to vinblastine, and this is less toxic, so this would be preferred. Radiation, of course, is avoided as much as possible in NF1. And because visual deterioration is often the trigger for starting chemotherapy in these children, there is also a role for giving bevacizumab along with, this is true for even non-NF1 children. So you could give bevacizumab along with the regular chemotherapy. So coming to targeted therapy, there's more and more role now. And in the past 10 years or so, there have been lots of papers which have come up. So which are the targets we're looking at? As we mentioned earlier, it is the RAS-RAF MAP kinase pathway, which is instrumental and central to all pediatric low-grade gliomas. So there can be inhibitors of BRAF. So BRAF mutation as well as fusion have got different drugs. There could be MAP kinase inhibitors, which are known as MEK inhibitors. And NF1 also, because it goes along this pathway, NF1 tumors also respond to MEK inhibitors. And just not related to this, but everolimus is also a very highly effective targeted agent, not in optic pathway gliomas at all, but in SEGA. So how do you decide which targeted agent is useful in which tumor? So one essential point is that we should try and get a biopsy in all cases that we are planning to start on targeted treatment, because we should try and find out if they are BRAF mutated or fused. Because BRAF mutated tumors generally respond to the first generation BRAF inhibitors. And what is found to be most effective is a combination of BRAF inhibitors plus MEK inhibitors. Whereas BRAF fused tumors respond best to MEK inhibitors or second generation BRAF inhibitors. You cannot give first generation BRAF inhibitors in like dabrafenib in BRAF fused tumors, because there is what is known as paradoxical activation of the MAP kinase pathway. So that's important to remember. Initially, in the late 2010s, we found reports of the efficacy of dabrafenib in, that is first generation BRAF inhibitor in BRAF mutated tumors. And here you can see that there were a lot of partial responses and complete responses in children who were started on this. And very recently, I think 2 years ago, there was this wonderful paper which came out from the Sick Kids group, which found that there was a randomization in children with BRAF mutated tumors, where they randomized to a combination of dabrafenib and trametinib. versus standard chemotherapy. So here you can see the waterfall plots, which found that there were significant responses, the best responses. There were a few complete responses, but a lot of partial responses, which are green as well. And what was very significant and striking was that the progression-free survival in children who received this dual targeted therapy was far better than those who received chemotherapy. So is this some magical drug? Let's see. There are a lot of toxicities which may be caused as a result of targeted treatments. These toxicities become less frequent after 6 months, and you could actually restart those drugs after at a lower dose when the toxicity is resolved. So that's one point, but we'll come to the rest later. And there are also these new drugs which are called pan-RAF inhibitors that's in trial. So these will work in all these tumors, and they are only to be administered orally once weekly. So I think we should look forward to such drugs. So why do we not just use targeted therapy in all patients if they are, they're all oral drugs? They do much better in BRAF mutated tumors than chemotherapy. Chemotherapy, of course, we know has its own side effects. It is a long treatment and given intravenously, so the quality of life is much less. Patients do not get to school when we do not get to go to school normally when we start them on chemotherapy, whereas with these less toxic targeted therapies, they are actually able to go to school. Unfortunately, targeted therapies are all now still available only in their innovator forms, so they're extremely expensive. So just giving trametinib at the lowest dose will cost us at least 45,000 rupees per month, and it could even be 90,000 rupees per month. And remember that the treatment has to be given for 2 years. So that is, something like 20 lakhs per year for 2-year treatment, whereas it would be like 1.5 lakhs for chemotherapy alone. So that's huge cost, but I think we can look forward to the fact that in a few years, we will start getting generics and hopefully targeted treatment, targeted therapy, which we have been using quite a bit at Tata, can be used more and more. But this again has to be very individualized. We cannot just blanket say that, we should think of giving targeted therapy to all patients. We have to make a conscious, individualized decision in all patients. So we already heard a very good algorithm, so I'm not repeating it again, but I just want to say that with chemotherapy, there's also an indication for giving targeted therapy. Since finances are a major constraint for most of us, I would still suggest starting with chemotherapy first, and especially if there are emergent indications like there is a visual loss or deterioration, we should go for chemotherapy first. So what are the long-term outcomes? The long-term outcomes in terms of just survival are excellent. And as we heard earlier, some of these tumors may actually regress or arrest in adolescence, and really, if they may not require further treatment. But very, very important thing is that the visual loss that the child has presented with may in fact deteriorate or stabilize, but it usually does not improve. So it's very important to make sure that they are rehabilitated as per vision, because there are lots of now low vision aids that are available, and we should make use of them. There are a lot of toxicities. I'm sure Uday will cover this in his talks, but we need to make sure that all these long-term toxicities are monitored for. So I'll leave you with a picture. This is the child with diencephalic syndrome we saw earlier, and this is her after her treatment, yet another child. So this was just to say that once the optic pathway glioma is treated, generally these children with diencephalic syndrome actually grow and thrive very well. That's it from me. Thank you very much.
Yeah. Thank you, Dr. Maya. That was very lucid and simple for a...
Am I audible, sir?
topic. Yes. So next I will request
Yes.
Dr. Uday Krishna. He is a senior consultant radiation oncologist, was earlier a faculty at Kidwai Cancer Institute, Bengaluru, and now presently he is working in Apollo Proton Cancer Center at Chennai. So Dr. Uday will cover the radiation therapy aspects for this optic pathway glioma. Over to Dr. Uday.
Am I audible now?
Yes, Dr. Uday, you can
Yes,
share
go
your
ahead.
screen.
Slides are seen?
No.
Not it.
Slides are not.
1 second.
You can please, yeah. Yeah, slides are seen.
Now seen, sir?
Yes, go ahead.
Thank you so much, Dr. Suhas and Dr. Ari, for considering me for this talk. I think we're also running a little late in the schedule, so I will try to keep it short and simple and try to see why, how, and when we consider radiation therapy for optic pathway and hypothalamic gliomas. I have a few disclosures, but the main important disclosure is I'll just be talking about non-NF1 tumors. I will not be covering NF1 because, as we know, radiation does not have a role in NF1 until unless very rare scenarios. So the first case I want to project here is a 14-year-old girl, very well educated, goes to American school, suddenly noticed visual losses on the left eye alone, and then the MRI showed disease going from the optic nerve going on behind. So she underwent debulking of the part which was posterior to the optic nerve, and then she received radiation therapy. And over 3 years now, and she is maintaining well, and then visual acuity has been stable without any much deterioration. And then the right side, I've just shown dosimetry showing how beautifully the brain beyond the optic chiasm and the optic nerve is very well spared with very high precision radiation therapy. And the second child who was diagnosed in January 2019 with this large lesion we saw in the previous cases as well, unfortunately had a large right MCA infarct during surgery and then became left side completely, was weak. Despite that, we gave VCR carbo for about 1 year, and then we managed to observe him for a long time. Finally, he required radiation therapy. Early this year, we gave radiation, and they prefer to take protons because he was still having a lot of deficits, and we wanted to avoid radiating to the contralateral brain as much as possible, and we could use the radiation through the already infarcted area of the brain. So we saw that he's stable now. It's about only 6 months into follow-up, but then he's doing very well. But as you can see, over 5 years of follow-up, most of you may have seen these reports, colored reports of fish with BRAF. So lots of things have changed with optic pathway glioma. Most of them, as we know, have been discussed extensively by Dr. Maya and Dr. Ari, are RAS-driven pathways. Rearrangements of BRAF and are common, and less frequent mutations like BRAF V600E mutation, FGFR mutation, NTRK can also be seen in these. So as was told by Dr. Maya, this can be either through NF pathway on the left side or through a non-NF pathway altering the BRAF, BRAF and then causing cell cycle progression, proliferation and other issues with this optic pathway glioma. So a normal BRAF on a fish looks like this. You can see that the BRAF locus is seen in green. The centromere probe is seen in the red. But when it gets altered and it becomes BRAF, and this most commonest type of mutation or commonest type of fusion of BRAF and then KIAA 1549, you can see this intermediate orange signal, which actually is the culprit. And this is a reason for probably the formation of glioma. But then these children are known to do well. Children with BRAF fusion, pilocytic astromas are known to do well compared to those children without these BRAF fusions or with other things. So as you can see here, it's just depicted that it's a tandem duplication. You can see that intermediate strand is sort of duplicated between BRAF and Ka6, and then the commonest among all the exon locations, the commonest is between 9 and 18. And they found that compared to the NF1 associated optic pathway gliomas, where 100% are not BRAF fusion cases, the non-NF1 can be as high as 61% with BRAF fusion or BRAF altered cases. So why is it important? As we know, as Dr. Maya has told in a very detailed manner, VCR carbo was the treatment of choice, meaning even now VCR carbo is used as upfront treatment with a very good event-free survival of about 68% at 3 years. And this recent study, which Dr. Maya showed in a NEJM recently from Dr. Eric Buffet's group, when they saw that dabrafenib and trametinib, which are the targeted therapies against these fusions and mutations, showed objectively significant response on the MRI scans. So suddenly there was a shift in the treatment of these cases, and suddenly world started looking at giving targeted therapy and try to avoid the chemotherapy related toxicity. So, and there have been innumerable number of targeted agents, and recently the ISPNO, which happened in US, and when both of us were there, me and Dr. Maya, lot of work only on targeted therapy and very less on chemotherapy, and especially on pan-RAF inhibitors and trying to avoid the resistance mechanisms and other things. But issue is not very simple. As you can see in this table, the toxicity is very high. Discontinuation due to toxicity is about as high as 54%. Even the pan-RAF inhibitors have got significant toxicities, and these are problems with weight gain, fatigue, pyrexia, arthralgia. These are children who have to run, roam around, and then grow, run, etc. And then in these children, giving toxicities like weight gain, fatigue, pyrexia, arthralgia, I'm not sure if we are justified with all these things. And what is the issue with radiation? Although radiation is known to be very efficacious, gives 10-year overall survival, from the historical data shows 85 to 95% overall survival. Because of these toxicities, basically on neuroendocrine axis, neurocognitive, vasculopathy, second cancers, optic neuropathy, etc., radiation has been feared that it is feared so much that it is not used upfront, but it is pushed to later stages in the treatment, as Dr. Maya enumerated. But two important factors we have to consider is the late effects of radiation are inversely proportional to the age, and late effects are directly proportional to the dose and volume of normal brain which receives radiation. So let us see some historical data. Historical data, you can see that it is the 10-year overall survival, even with X-ray based therapy or conventional forms of modality of radiation like X-ray, 3D CRT or IMRT, also gave very significant high overall survival rates over time. But then toxicity, which was combined both NF and non-NF patients, shows that the vasculopathy can be high, endocrine deficiency can be high, but then all these are a mixed group of patients, and I'll go ahead and I'll show you how it is different in the current era. So if you see a large population-based study, coincidentally run by one of my previous colleagues in Tata, Rahul, they saw basically from Canada, Ontario, the state, and then they saw that in children who received upfront radiation therapy in a mixed cohort of all the low-grade gliomas across the brain, if you see there is significant improvement in the overall survival, and the hazard ratio is very less if you use upfront radiation therapy as against radiation therapy delayed for progression or failures of multiple lines of treatment. Continuation to this, what were the probable selection bias at several levels? Upfront radiation was used for more aggressive low-grade gliomas, which probably were already very aggressive to cause deaths. Biopsy only was done for deep-seated tumors, so we don't have a biopsy, and there was a biopsy bias. And then RT was offered only to patients who progressed multiple lines of therapy, which also could indicate that these were the worst biologies which were selected. So if you compare the high-risk cohort giving first line of RT versus delayed RT, and then the low-risk cohort of first line RT versus delayed RT, you yourself can see that there is significant difference in the survival over time, especially up to 360 months from radiation. And if you see the visual outcomes after chemo and after RT, they're not actually much different, because both of them depend on what the status of vision was before the start of radiation, before the start of respective treatments. And so RT does not have actually much significant difference compared to chemotherapy in terms of causing further worsening of vision. And in fact, if you see the visual acuity in the worst eye was diminished at the baseline itself with administration of chemotherapy before CRT, and probably progression of the disease prior to chemoradiation, and probably that was the masking reason for showing up as if it was worsening of deterioration with radiation. And this study from St. Jude's has shown over time after completion of conformal radiotherapy, you can see that although already the replacement levels of thyroid, cortisol pathway, the cortisol pathway, the growth hormone, the cortisol, the thyroid, all these axes were already impaired, and this over time actually flattens and does not worsen further with a good conformal radiotherapy. And so in order to understand all these things, to see if RT is really helping in terms of improvement in the vision and improvement in terms of tumor control, we actually need better tests. if you see the testing pattern from before has now changed. We just don't use only visual fields and visual acuity. We also use something called as optical coherence tomography, and we see the measure the retinal nerve fiber layer thickness, and this actually is a non-invasive test and detects early changes in the VA, and VF detects defects. Also, radiologically, if you see this case, for example, although you don't see much change in radiology over time, if you use good high resolution and high level scanning, like something like this is something called as APT, which has been designed in many centers, but then has been regularly used in our center in Apollo Proton. What you can see is over time from February to June, you can see that there is significant shrinkage in the perfusion level of these tumors, which was supposed to be one of the most indicative markers of a BRAF-fused pilocytic astrocytoma. So I was fortunate to be a part of this randomized control trial in Tata Memorial Center. I have just enumerated how do we do the immobilization. MR is used actively for all the patients for fusion with CT scan for planning. The margins we use for the target is very low. High quality assurance is used before treatment. And then dose distribution, as is shown here, is basically of a conventional radiation therapy. And this randomized control trial, which had about 30% of patients with optic pathway glioma, showed significantly less neurocognitive and endocrine functional outcomes. So when I say less endocrine functional outcomes, it was split into two different categories. One was to see if these children developed a new endocrine dysfunction, which was significantly less if you use a conformal radiation technique. And if these patients, did they develop additional endocrine axes when they already had some endocrine deficiency, also was significantly different between these two. And then the IQ, as you can see in the upper two graphs, was significantly better with conformal radiation therapy. And we published this data on avoiding of hippocampus in these children, because these children, as Dr. Maya showed, go on and become better, and then they survive for longer years. So you want to make sure that their IQ, they're cognitively very good. And you can see that the full scale IQ was significantly better with a better form of radiation therapy. And then these are the contemporary radiation technologies what we have over across the country. And although every single technology is very good, this what I've highlighted is something called as an integral dose, which is the dose deposited per gram of tissue. So if you are treating a 6-year-old child with a brain mass of X, and if you're treating a 12-year-old child with a brain mass of X, and if you have to treat the same volume of disease, the integral dose is a dose deposited by a gram of tissue of brain, goes on increasing as you use more and more high precision X-ray technique. So in that perspective, what has happened is proton therapy has taken up in a bigger way in the world as of now. And when carefully chosen in optic pathway glioma also, actually what I have shown you is a case of an ependymoma, but if you can see that the difference in the dosimetry between the conventional radiation technique and the proton 4-field technique. But if you use it selectively very well even in optic pathway gliomas, you can achieve these results. So why proton therapy is preferred? You can see the yellow area is the extra radiation dose what the normal conventional radiation they can deposit compared to proton therapy, which is the brown line, which is sharp fall off. Why this happens is because they are very heavy particles. So their dose deposition in water or in the tissue is more dense compared to this. And with the physics concept called SOBP, wherein you can see the graph that it is very tightly hugging onto the tumor, and there is no radiation beyond the target area, you can try to achieve as much as possible. Over years, there has been evolution of this technology, and right now we use various energies across the target to make sure that we don't use uniform energy, and so that the radiation dose deposition is less. Outcomes of radiation has been excellent, especially with especially of tumors around optic pathway is very good. As you can see, local control beyond brainstem is excellent. Doses are not very high. We just need 50 gray of radiation. And then the serious late toxicity is very negligible. It's about 22% of these actually develop new central hormone deficiency. The endocrine outcomes, visual profiles, everything is mostly encouraging. And to conclude, when do we use radiation therapy? If possible, you have to use it upfront if you think it is probably going to be challenging location for the chemotherapy and the targeted therapy to act, or if there is progression on post-systemic therapies. Ideally use a conformal technique, and if possible, wherever feasible, wherever case selection on a multidisciplinary in a multidisciplinary manner, proton therapy can be beneficial compared to conventional techniques. Long-term outcomes are definitely more superior compared to conventional radiation. And then survivorship issues like long-term monitoring is required. Vasculopathy predominantly is seen in NF-associated diseases. Second cancers are very low. I didn't want to show the slides today because of want of time. The neuroendocrine outcomes, although it is already existing pre-radiation therapy, it would not I showed that it would not worsen after completion of radiation therapy, because the dose which can cause actually panhypopituitarism is much less, and this can be significantly low. With that, I think I will stop, and I will be happy to take any questions. Thank you so much.
Thank you. It was a very nice overview of the radiation involvement and treatment of OPGs. I think I've not got questions in the chat box. So what I'll do is I'll pick up some simple questions for all three of you, so that which I thought will require a bit more of clarification for the sake of residents, and I'll do the job for them. So Ari, I had a small question for you, a very simple question, straightforward one. Now, can you enlist again indications for biopsies in OPG?
Am I audible?
Yeah. Indications for biopsy. You said you give us a clear list of indications for surgery. I'm just asking indications for biopsy in a radiologically OPG appearing tumor.
If you go by the literature and the consensus guidelines, there is a paper which is published based on consensus guidelines from Paris 2011. If you go by that, they say that there is no indication for a diagnostic biopsy in an optochiasmatic glioma unless there is a uncertainty in imaging diagnosis, or it is done as a part of a clinical trial or a research. That is in 2011 called, I think I showed you a paper on that. Whereas now, that said, most patients we consider doing biopsy now because of two reasons. One is the oncologist would request us to have a biopsy to molecularly characterize them. And number two, also for other medical and treatment purposes to confirm the diagnosis. I would definitely, the biopsy will not be indicated in a case of an optic nerve glioma where the imaging is typical. So in optic nerve glioma, biopsy is definitely not indicated. Whereas in an chiasmatic lesion, biopsy will be indicated. Indicated now, meaning it is practiced for now for molecular characterization as well as for confirmation of diagnosis.
Okay.
For lesions which are more posterior, like in hypothalamic or optic tract, they often present with large mass lesion. There, the surgery is often not for biopsy, but for the lesion decompression per se, because they are often exophytic and can be decompressed sufficiently so that the further adjuvant therapy can be given for a smaller size of the lesion.
Okay. I do have had situations where diagnostic indications where you have a diagnostic doubt, you biopsy. So
yeah, when imaging is not typical, then biopsy is definitely
indicated. Yeah. For Maya, I had two questions for you. One is, let's say an extreme failure to thrive. Would you at any stage hold on with chemotherapy or deny treatment? Extreme failure to thrive, diencephalic syndrome, who's very, very sick, or how would you modify the chemotherapy? You're muted. You're muted. Unmute your, please.
So, normally, if the child is stable, other than the fact that the child is extremely emaciated, if the child is otherwise stable, we would start chemotherapy at modified doses. There are modifications which we make for severely malnourished children. So we would start at these very low doses. We would also start aggressive nutritional rehabilitation and endocrine corrections if required, hormonal corrections. And then we would, as per tolerance, we would go step up on the chemotherapy. So unless a child is unstable, comes into the ICU or is extremely sick, we would not withhold chemotherapy. We would still give chemotherapy.
The second question to you too. Can targeted therapies be first line at any point of time? First line.
Yes, they could be first line. So now in the West, they are definitely first line. And there have been, so they're very expensive. That is the reason, that is the main reason that we do not offer them in the first line. Secondly, they are available as tablets which need to be swallowed whole. So we are not able to give them in younger children. But if children are 5 years or above, they are usually able to swallow. So cost as well as the inability to swallow the tablet are usually the relative contraindications for not starting them in the first line. But we do have several patients who are able to afford by themselves, or what we have been doing is we have been leveraging a lot of schemes, because this huge cost is split over so many months. If we are able to provide that seed funding, we then apply to a lot of these trusts as well as government schemes, so that we can provide them the drug, subsequently. So we have started in around, I think around 30 patients of ours have received targeted treatment, and around half of them will be in the first line. Most of them have been able to afford the treatment on their own. That's how we've done it.
Then for pure optic nerve gliomas, which do not involve chiasm, do you see a role for chemotherapy there too? Pure optic nerve gliomas.
Yes. So if there is, especially if there is a loss of vision, we do give chemotherapy. There are patients in whom we've given chemotherapy.
So the parallel question to Uday is, Uday, optic nerve gliomas without, let's say, no proximity to chiasm. Don't you think radiation can be considered as first line?
It can be considered, but it
As
depends
first
on
line.
depends on what is the vision. If
No,
suppose
it's only an infant with an optic nerve glioma. You
we
cannot
generally don't
judge the
consider,
vision at all.
we don't generally consider as first line.
Because
we generally try to meaning the complications in
no,
and
it's an
around.
optic nerve glioma. It's completely within the orbit. It not at all intracranial.
Yeah, generally, if the vision is preserved, we try to do chemotherapy and then try to reduce it further and postpone the RT as much as possible as compared to the more posterior ones. That has been the practice worldwide.
Yeah, I'm just wondering because ONG is a very actually a rarer entity. We don't see ONGs, primary ONGs, so frequently. Ari, you want to comment on it?
NF associated. Usually, they are NF associated.
Yeah, but at the same time, a single one. I mean, optic nerve gliomas per se is a very. Ari, you want to?
Yeah, optic nerve glioma is a
Purely,
dilemma. Yeah,
no chiasm involved.
No, that's an optic nerve glioma is sometimes a dilemma, and I get a feeling that it's difficult to make a decision at first contact because we do not know how it will progress, and it will depend mainly on the, like what Dr. Uday was trying to say, what is the vision? If the vision is well preserved or stable, and if the patient has enough one, then there is no question. We just have to wait and watch and see whether it progresses. Many times it may not progress. In case if there's a progression or if the vision is poor, then in young children, earlier the cutoff was 5, now they are taking it to 10, and there are paper like I showed, the Eric Buffet's paper, they're considering primary chemotherapy even in adolescents. So chemotherapy would be the first line of choice. But what I have seen over the last many years, when like Dr. Maya made a point, when we give chemotherapy, we should not expect that the tumor should disappear. In most cases, the tumor just remains the same size. Probably does not progress and the vision stabilizes. So chemotherapy would still be a choice. However, in like the 2 patients which I showed in my presentation,
painful proptosis,
more than 10 years with who came with visual deterioration, almost like counting fingers close to face. So we considered giving radiotherapy for stabilizing, and then they in fact shrunk and had some visual improvement. So I think older children, visual deterioration, I would consider radiotherapy because, like you said, they're away from the brain, so or toxicity may be less. In younger children, like if you're saying is an infant with the optic nerve glioma, then either wait and watch or chemotherapy. We don't have any other choices there.
what if there's a painful proptosis or a proptosis which is very troubling?
Like I said, the indication for surgery, of course, I've seen people, there have been discussions there, we say we can go in and decompress. Optic nerve is a very, very compact, full of this one. It's very difficult to preserve function when we don't know where the function is. So if the patient has got good functional vision, the incidence of deterioration is very high with surgery. So surgery would not be indicated unless there's a complete visual loss, wherein, like I showed in the paper, if you go in for surgery for an optic nerve glioma, most often it will be at complete visual loss. Then we have to completely resect the whole nerve up to the level of the chiasm, or if there's a painful proptosis. Otherwise, just for a biopsy or a decompression of the optic nerve would not give a reasonable quality of life or a visual outcome in that patient. So surgery would not be a choice there at all.
Uday, one question for you. Can you clarify again the timing of radiotherapy? Exactly. When do you bring radiation into the whole scheme of management?
Definitely not for a young child younger than 3 years. Between 3 and 6, over years, meaning when I was a resident to now, what we have been taught or what we are teaching now is definitely not in a very young child. And when you have a large lesion like involving the optic chiasm tracts posteriorly, a large lesion to cover, which obviously will cause radiation toxicity, you would not want to treat such children. If suppose there is no response to chemotherapy, you can at least you try chemotherapy for 6 months, or targeted therapy whenever there is affordability is not an issue. 6 months is the time period what most of us consider as radiation oncologists to see if it is really responding to radiation. However, BRAF fusion positive optic pathway gliomas are known to respond to radiation therapy better compared to chemotherapy or targeted therapy. We are in the process of analyzing our own data and publishing it, but worldwide there is some movement that BRAF fusion meningioma, BRAF fusion optic pathway gliomas in an older child, probably older than 6 years, you would consider radiation therapy right away and not wait and watch for chemotherapy or the targeted therapy to act.
Dr. Maya, you want to comment on this? When would you?
So as I think, as Uday mentioned, the goalpost is being shifted further and further away, and it really depends on the location of the tumor. So I think in a hypothalamic tumor, right now, there are centers who would wait till even puberty is attained to give radiation because, once that's achieved, a lot of the hormonal supplementation and everything that you have to give is then reduced. But that depends on if you have the luxury of giving all those treatments until you can defer radiation to that timing. So I think it has to be, like we all mentioned earlier, it has to be very individualized. Try to differ as much as possible, because it's not just the hormonal or the neurocognitive problems. There are also these very late things. I think that's what Uday meant by not wanting to give radiation even in these optic nerve tumors, because there can be vasculopathies, there can be second malignancies in any irradiated area, and the dose that's given for these tumors is pretty high. So, I mean, these are potential very late toxicities which come out much later, and probably we need to try and avoid those if possible. So if we have the luxury of delaying it, then delay it as much as possible. But if there are emergent indications, especially as Dr. Ari mentioned, if there is an impending visual loss in an older child, definitely don't wait for anything else. I think we have to try and save the vision as much as possible. So those would be indications in which we would give a radiation irrespective of, any other consideration.
I have
Okay.
a few questions, if that's okay. I mean,
Yeah.
there is one question also from the chat box, and I don't know, Dr. Sukas, whether the audience can ask questions or
Yes.
or
They
they can
can.
only do that. They can only type it in the
They
chat.
can move. They can do both. They raise hands. We'll unmute
So
them.
I
No
see
issues.
there are residents. If
Yeah.
anybody wants to ask, maybe they
Yeah.
can ask.
Yeah.
There is one question from
Mac.
Dr. Gupta. Is there any role of radiation followed by surgery? I'm not clear whether it is first radiation, then surgery, or surgery followed by radiation. I'll assume radiation, then surgery. I will just want to make yes, first radiation, then surgery. So, like I showed, if you remember the slide that I showed from Eric Buffet's paper, there is no set order in this particular condition. It's not like, if you're talking about a glioblastoma, we say always surgery first, decompress, then radiation, concurrent chemo, then cyclical. Here, it is individualized. In case if a patient receives chemotherapy or radiotherapy, we are expecting the tumor to be in remission. They may shrink in some conditions, or it may remain the same size. But these patients need to be followed up. In case if the treatment did not work, or after some years, if the tumor starts growing, then surgery definitely will be considered if the tumor is exophytic and the tumor can be decompressed. Instead of waiting for the tumor to grow well beyond control and then thinking. Surgery in case of, there are a lot of papers of surgery in relapse of these tumors. It should not become like a salvage surgery, that rather it should be a tumor decompression early in the case of relapses. So surgery should be and can be considered in case of treatment relapse, either following chemotherapy or following radiotherapy. So that is still an option. But every time the goal of surgery would most often be a subtotal resection or decompression and not a gross total resection, because here the substrate involved is a very, very functional tissue. That is
Eloquence, yeah.
something which you need to remember. My question to Dr. Maya is, I have seen that like we had a practice of often radiation earlier, and patients who go for chemotherapy, because this is a 1-year treatment. Is it essential that every child who undergoes chemotherapy has to receive weekly injections for 1 whole year, or is it again this, for my understanding, like they receive for 1-2 months, then there's a break, or is it like every child should get 52 weeks of weekly injections? Because many parents may not, the compliance becomes an issue there when someone has to take it for 1 whole year in these patients. So that's something I wanted to understand.
You're mute, Dr. Maya, you're mute.
Yeah, I keep forgetting. Yes, chemotherapy is actually for in the shortest form that it is there is 1 year. Some people actually give it for even longer. So almost 1.5 years as per the SIOP, the European protocols as well. And it's given for the first 3 months, it's given weekly. And after that, it's given 3 to 4 weekly. So that's, as far as patients and their families are concerned, it is a huge, drain on their time, and a lot of children are not able to go to school. So if they are maybe taking it in their local same hometown, it's fine. But those who come from out of town, stay in another city, are totally stuck in that city when they have to get chemo. So that is a huge problem. That is one of the main reasons that I think, people are tending more towards targeted therapy, which is given oral. And that way you can pursue your normal life.
Yeah, the second question is this again, what I keep wondering when we manage this patient. If you go by literature, if you look at the data, most of them are Western literature, and we have some from India. They say surgery, biopsy, its role is limited if you take a biopsy confirmation in large tumor and then consider for chemotherapy. No need to decompress, because these are primarily treatments is given by adjuvant therapy. However, like what I've seen and what you showed also, the targeted therapy is not very prevalent in our country. And in chemotherapy, like you said, it's a long-standing treatment, and that most of the patients which I have seen in our treatment group cohort, the tumor has remained the same or maybe 5 or 10% reduction in size. Whereas in some of the patients which we treat with radiotherapy, like I showed in my presentation, some of them have shown significant reduction. So toxicity of 2 different modalities apart, chemotherapy, what I understand is it stabilizes or minimally reduces. So in that context, if we can do surgery and decompress the tumor as much as possible, especially the exophytic lesions as well and the hypothalamic lesions, would it not be better for the children? Because then you have to deal with a smaller size of the lesion instead of having a large mass sitting in the brain, which will remain the same size for even after years with the 1 year of chemotherapy. Like when the patient comes to us for follow-up, we see the scan and say tumor looks the same to the family. So obviously every family expects after so much treatment, surgery or whatever therapy, for the clinician to say the tumor is reduced by half or quarter or whatsoever. So we'll not be able to tell. So my question is, should we consider more aggressive surgery, or rather, I don't want to use aggressive, more proactive surgery to reduce the tumor volume without increasing the visual morbidity?
I'm not sure I know the answer to this as well, because we have had these very large tumors like the child I showed in my presentation as well. But I'm not sure. We have often discussed debulking, especially because the tumor is just so large, and because it was, maybe why have such a large tumor? But I think the literature itself is so scanty in this regard, and it's always said that there is no advantage to debulking surgery. That I don't think I know of a single patient who has had this kind of approach. Although it really seems very intuitive to do that. I mean, what you said
No,
is
there are many papers from
sounds, yeah.
neurosurgical literature that we have literature where they have shown debulking, but then if you look at overall survival analysis, they will all look the same. But then I'm thinking is when the tumor starts growing, it's better that you have a smaller tumor starts growing than already a large tumor. So for overall in a long-term perspective, especially the exophageal tumors, I think more proactive decompression may be useful. This is what I'm thinking. There are
Yeah,
a
I
few
think,
questions from chat box. I think you would like to take regarding chemotherapy, radiotherapy.
So one question about chemotherapy causing second malignancies. Generally, the chemotherapy that we give does not cause, but there used to be a regime called TPCV, which was actually a very effective regime. It had a lot of side effects, including the potential to cause second malignancies. So that's not used very commonly now, but the two most commonly used regimes, which are vincristine, carboplatin, and vinblastine, usually do not cause second malignancy.
okay. I think Ari, Dr. Uday and Dr. Maya, we're running out of time. Shall we close? If it
Yes, please.
agree, yeah.
Yes.
Do you have any final comments? You're free to do that, please. Anything final? Yeah.
I think,
think-
if I can
Yeah,
just
Uday,
make a short
go ahead.
comment.
Go ahead.
Proper evaluation of vision and before any treatment, and good baseline MRI, I think, is very critical for these children, because most of the times the assessment is not just radiological. Many of them may not have access to good MRI scans, so the assessment would be only vision. So I think a good visual evaluation initially, and then discussion with the family as a multidisciplinary team as to what they want and what we can offer under the given circumstances. Because I have worked in Kidwai before, as Dr. Ari told. So I have seen children, families finding it very difficult to even understand what a good visual evaluation is. And if suppose the same institution doesn't have visual evaluation, it becomes very difficult for us to make them understand what we are asking them to do. So I think a very good baseline evaluation of vision, endocrine, and then what the family wants and how much do they understand by what we are trying to say, because these are essentially benign tumors. Children are going to live for many years. And then how we sequence our treatment and what we use initially and then what we use later, and how do we time these things is very essential. And by and large, all the institutions across the country use chemotherapy first. I have to admit this very honestly. The chemotherapy starts off while we are waiting, and I mean to say after a biopsy is taken or whether biopsy is not taken. And then many a times even radiologically, and then and radiation usually comes later. If suppose we can have a multidisciplinary discussion at the baseline with all these parameters, I think that makes it more meaningful.
Thank you, Uday. Dr. Maya and Dr. Ari, any comments?
Yeah, thank you. I just want to make a small, this patients need multidisciplinary
MD.
management. That is very important. One discipline, if should not be considered, then because then the bias will creep in, and each patient has to be individualized, and this needs a lot of cross discussion between different groups so that what is best for that particular patient can be decided. So there is no one single uniform treatment protocol.
Yeah, thank you, Dr. Maya.
Thank you.
Anything?
So I agree with absolutely agree with what both of you have said, and I think in relation to what Uday said and what we discussed earlier. So these 2 or 3 lines of chemotherapy and many years of the of a very poor patient's family's life and wages and everything lost. Sometimes some of them they may be happier to get radiation even at the age of 7 or 8 years. So that is another thing which we should probably discuss with them, and also as mentioned earlier, to just listen to them, and maybe it works. Some things actually work much better because it's just 6 weeks of radiation and not these 2 or 3 years of staying somewhere else and getting treatment. So
Yeah,
I think many aspects to be considered while deciding on what's the best treatment.
Dr. Naveen, any comments?
No, I do agree. I think it's a very
Yeah.
controversial topic, and that has been
Yeah.
beautifully covered by Dr. Ari, Dr. Maya, and Dr. Uday. I think there are a few very good take-home lessons for the residents also. So I think I really thank them for the time, and really they have really worked good for the residents. Thank you, dear. Thank you, everyone. Good
Thank
evening.
you very much for the opportunity.
Yeah, thank you, Dr. Maya.
Thank-
Thank you, Dr. Uday. Industry appreciates your contribution greatly. Thank you, Ari, for
Thank you very
coordinating
much.
between all of us.
Yeah,
And
thank you.
for all the residents, these sessions are the last Sundays of every month. Continue joining us. The next one would be on medical oncology, an overview by Dr. Girish from TMH. Thank you, Dr. Uday. Thank you, Dr. Maya. Ari, thank you. And thank you, everybody. Thank you.
Thank you.
Thank you.
Thank you, Naveen, joining.
Thank you so much, sir. Thank you, everyone.